good morning, good afternoon, and good evening to all the friends, all the teachers and delegates and participants for today's session. I welcome you on behalf of ACNS for this ACNS YNS webinar, which we conduct for the sole purpose of education on every second and fourth Sunday. And today we have yet another interesting webinar where we have Professor Yoko Kato as the Chief President of ACNS, Dr. Sharon, who's chair of ACNS WIN chapter, and she's a senior consultant at APJ Johar Specialist Hospital and senior lecturer at the Monash Medical University. Professor Alexander Wozniak, who's the president of Neurosurgeons Association of Ukraine. He'll be joining us soon. Dr. Abhidas Shah, who's the assistant professor neurosurgery at GS Medical College and KM Hospital, Mumbai. And for the guest speaker, we have Professor Manabu Tamura Sensei today, and he'll be talking with us on the contemporary management of intracranial gliomas, predicting surgery using intraoperative MRI and awake craniotomy, an interesting topic. And as a YNS speaker, we've got Dr. Dragan Jakovic, a young dynamic neurosurgeon from Germany, who's a neurosurgeon resident at Department of Neurosurgery at University Medical Center of Mainz in Mainz, and a PhD student of neuroscience. And co-moderator with me, we have Dr. Liu, Dr. Ben NG, Dr. Sneha Chitra, and Dr. Asif. So I request Professor Yoko Kato to say a few opening words, and after that, I would request Dr. Sharon to say a few words as the chairperson. Professor Yoko Kato.
Yeah, thank you very much. So good evening in Japan. So I'm so happy, or we all happy to receive the two speakers. Tamura Sensei is very famous, especially the Tokyo Women's College. He is the backbone of his research work, I think. And Dragon, and he's coming to Japan in next February and March. So we all expecting your arrival, so that we can start. Thank you very much.
Thank you very much.
Thank you. Dr. Sharon, can you please say a few words since you're the chairperson for today's session? Dr. Sharon, are you there? Okay. I'd request Dr. Ben to please kindly introduce our first chairperson, Professor Manabu Tamura, and then request Professor to start his presentation. Can you please introduce Professor Tamura?
Yes, sure. Can you hear me?
Ben.
Sure. Can you hear me? So
Yes.
Professor Tamura is the associate professor with the John Graduate School of Tokyo Women's Medical University and Waseda University. As a cooperative major in Advanced Biomedical Science Institute of Advanced Biomedical Engineering and Science, Faculty of Advanced Theological Surgery, Department of Surgery, Department of Neurosurgery, Tokyo Women's Medical University in Japan. So, today is our honor to invite Professor to give us a lecture titled "Contemporary Management of Intracranial Gliomas: Predictive Surgery Using the Intraoperative MRI and Awake Craniotomy." So, without further delay, may I invite the professor to share the screen?
Yes, I will try. So let's try my presentation to share this one or this one. Let's start. Okay. 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 It's a good.
Is this the last
good sharing?
Professor?
That's right. Oh, sorry. No
problem.
No problem. So
You can start from the first slide, Professor, please.
Yes, from the first slide. Okay. So this, I think this is the first slide.
Yes.
Yes. Here it is.
And I'm just afraid this the missing the video, but I will start. Okay. Thank you. Let's start my talk. So good evening, everyone. I greatly thank to give an opportunity for my talk by Professor Kato and all the organizer of this ACNS YNS meeting. My name is Manabu Tamura from Tokyo Women's Medical University. I would like to present my presentation and share with you. So here is today's agenda. Firstly, I introduce our team and facts. Secondly, I explain our preoperative and intraoperative management of intracranial gliomas. And finally, I'd like to talk about predicting surgery and telesurgical support in our institution. So firstly, I introduce my team and facts. So before going to today's topic, I would show this slide to introduce our laboratory, Faculty Advanced Technosurgery. This is FATS. FATS is multi-professional faculty developing novel surgical device for cancer treatment and surgical science. So there are four neurosurgeons, 7 engineers coming from different universities. 1 pharmacist, 1 psychiatrist, and 21 graduate students, 15 from company. So this is our snapshot in 2015. So this is scheme of our precision-guided therapy, which providing safe and reproduce treatment. So most important part of new eye, this shows this new eye, shows a new eye. So this new is providing solid intraoperative visible data and strategic desk analysis, different kind of information and advice to the operator. At this point, manipulation itself is done by surgeon's hands. We are developing new hands such as laser and focused ultrasound and robot manipulator. This part is information-guided surgery. So why we call it information-guided surgery? So modern image-guided surgery is fine, using intraoperative MR and update navigation contribute higher resection and lower complication rate. So beyond that, to achieve higher goal, we propose information-guided surgery. Shows. So this one, in which decision-making could be done also by functional mapping or MEP monitoring of functional information and histology of frozen section, histological information. So how about function information? So we'll show monitoring of motor evoked potential is to check motor function, and mapping by electrical stimulation underway craniotomy. So let's start. So this shows, I will show pre-operative management about SARSI labeling using brain visa software. So we have studied about SARSI auto-labeling from MRI T1 weighted image using brain visa free software that represent brain SARSI and jury in 3D, compare with normal brain and auto-label patient's brain as to object-based morphometry theory. So we would like to show the methods about 3D views of GRA and SARSI with labeling. We analyzed 220 cases for this study, analyzing surgical information, that is surface area in blue, lengths in red, maximal depth in yellow, and average opening in light blue. So we show the two cases related to the correspondence. First case is to say the corresponding case between preoperative labeling, it's A, brain visa, and real central sulcus by SEP in OR, it's B. So A and B is correspondence. So turn to the simulation using the preoperative T1 MRI. In this right parietal region, pre- and post-operative simulation is performed in 3D view. Here is pre-surgical simulation for post-tumor removal. And this 3D view is quite similar to real view after tumor removal. So I conclude firstly, 3D view and circle labeling from volumetric T1 weighted image MRI was useful to recognize the presence of anatomical and spatial relationship and to simulate the removal procedure in glioma surgery. Secondly, pre-surgical central sulcus labeling was accurate, 95.5%. Finally, cell-side imaging can be applied to obtain more informative perisurgical evaluation for accurate and safe glioma resection in neurosurgery. So the second, we introduced preoperative management about using diffusion tensor imaging. As to neural fiber tracking and simulation, we use DTI tractography as well as FA color map as anatomical information prior to tumor resection. In DTI tracking with LOI or brain stem, only CST near lower limb was described and not visualized for upper limb fibers, which means false negatives. As motor function in our experience, DTI tractography was not so reliable for upper limb, which means false negative. So DTI FA color map and the navigated TMS transmagnetic stimulation compensated the tractography. And finally, we confirmed with SEP and MEP monitoring and direct manual muscle test in OR to avoid complication. So let's see, the other hand, preoperative navigated TMS revealed monitoring APB muscle contraction as a preoperative motor function area, as upper limb motor area here. So finally, we could confirm the real motor function with direct response by electrical stimulation on cortex and direct muscle contraction. See here. So as the language function, DTI tractography was not reliable for accurate fibers, which means false negative. So DTI FA color map and functional MRI compensated the tractography. But finally, we confirmed language function with mapping and monitoring in intraoperative examination during awake condition. So here is an example of left frontal region near language fiber. ADC and FA color map showed an anatomical information between tumor and surrounding neural fibers. We preoperatively simulated with total DTI tracking and fMRI with grammar task. I will explain later. So this slide shows
いちご。はい。せーの、はい。犬。
Can you hear the video? Okay.
はい。OK。せーの、はい。
う
さぎ。OK。なんか、同時先生以降。なんか同じのが出てますよ。いいよ。いいのよ。バレました。名前。これで、じゃあこれからちょっと手術始めるので、ちょっとね、厳しい感じ。はい。何がですか？言葉の集中が、はい。塩の上にあるんだな。塩の上？うん。いやー、トナカイは何これ？トナカイは。塩の外にもある。
Sorry. So this is the video.
松ぼっくり。松ぼっくり。違うな。これは松葉まで合ってます。松葉。わからない。なんだろう。これは
I would like to just confirmation the video. Can you hear the video? Okay. Okay, I will start again. So as we showed the false negative in DTI tractography, we have to perform maximum tumor rejection to avoid post-operative complication. So here is a now solution that will be useful for this purpose. So more detailed DTI to analyze precisely visualization preoperative upper limb function by navigation TMS, navigated TMS, post-operative cranioplasty with a metal device to avoid artifact, and fused intraoperative MRI with preoperative DTI FA column map, and language evaluation using pre and intraoperative CCEP. So we use fused intraoperative MRI with preoperative DTI FA map to solve false negative in tractography. I will explain this topic in the following slide later. So we put the electric strip to monitor language function during tumor removal. CCEP deterioration was corresponded to the deterioration of language function. So we summarize the role of preoperative DTI tractography. Now in deterministic methods, we have false negative indeed. However, DTI FA column map and other material compensated the motor and language function. Actually, awake craniotomy can perform manual muscle tests and intraoperative examination and still go to standard for functional mapping and monitoring. So we concluded, firstly, DTI were complex models of white matter's anatomy that can provide clinically relevant information for the planning of glioma surgery in motor and language areas. Secondly, clinical evaluation of DTI techniques can establish the variety of DTI-derived information to assist with neurosurgical decision-making, especially in awake craniotomy. So preoperative management about functional MRI, I'll explain. So in the literature, we found various activation in language tasks on FA functional MRI as follows: a slowly listening, silent reading, silent word generation, sentence repetition. So we obtained more specified, that is localized activation with picture sentence matching tasks than other tasks. Show these three kinds of tasks: active sentences, passive sentence, and scrambled sentence. We can choose in the right or not right in the MRI room. Exactly. So this is data, one data. So here is our data concerning the corresponding of functional MRI and intraoperative functional mapping in 30 cases. The correspondence, including partial one, was 93.3% of the cases, and our identified speech area was located widely, not only in F3, TR, or operculum, but premotor cortex in the middle frontal lobe. So we conclude, firstly, activated regions using preoperative fMRI with the picture sentence matching task closely corresponding to language-related regions determined with functional mapping during a craniotomy. Secondly, further examination of grammar centers in the brain should be investigated with functional mapping and will potentially contribute to our understanding of human language. So let's explain the intraoperative management about combination between preoperative DTI and intraoperative MRI. So this is a newly developed system in which an FA color map as an objective measure of neural function from preoperative DTI is combined with intraoperative MRI image obtained after craniotomy. So in case one, we indicate a navigation based on preoperative pyramidal tract motor function information. Under general anesthesia, tumor resection is advanced, while the pyramidal tract in blue is monitored in real time using the newly developed navigation system. Let's see the video. This video shows the intraoperative MRI and updated navigation fused with preoperative DTI FA color map. This is postoperative intraoperative MRI scan. So in case 2, we indicate a navigation based on preoperative accurate fibers language function information. Under a craniotomy, tumor resection is performed while the accurate fascicles in green is here is monitored in real time using the newly developed navigation system. Also, in this case, very interestingly, preoperative accurate fascicles in which the joint eye movement center is identified based on language function information and language function text. So under awake craniotomy, the tumor resection is performed while the white matter fiber in green related to the joint eye movement center is monitored in real time. So using the new developed system, you see that this patient eye is deviated to the right. So when we stimulate by the electrode rod, so the language resection is associated with the present this language. So in both the surgeons and examiner, making the system very highly useful for awake surgery. Here. So we conclude co-registrating an intraoperative MRI and a preoperative FM color map is useful and practical method to predict the location of critical white matter nerve function. So let's awake craniotomy using our developing EMS. When we confirm patient's language reaction at the picture naming task in our craniotomy like this. There is 2 patterns. If electrical stimulation hit language function area, the patient could not answer, while stimulation hit non-language function, he can answer. This slide is the history, how to examine the language function showing papers, personal computer, and our newly developed EMS monitor in TWMU. We continue to develop this tool as a medical device, and from 2013, we can provide this language examination tool for cell surgery for cell all over the world. This is video of examination for language function using EMS. So this circle electrical stimulation scene capture is showed. So here is a demonstrating to the task for language examination in EMS monitor. So this is a task controller. This is a task display. As the patient can see that this task. And from patient view, it's like here. So we catch the patient face from this camera. So patient face here, this task from patient, and microscopic viewing here. This is a surgical navigation system. This is anesthetic conduction that is like this monitor, the anesthetic findings, and overall viewing in operating room. So this shows real-time display of all the information in the same time is recorded.
タイヤ。いいですね。はい。せーの、はい。何、トラック？はい。
So here is a video showing our international EMS.
ハンガー。
はい。Understand this system.
はい。バイク。はい。せーの、はい。バス。いいですね。はい。せーの、はい。バナナ。はい。せーの。
So,
はい。
so I would show the illustrative cases using EMS. Are they the case of speech arrest, aphasia, or dysarthria? So mapping during tumor removal.
1、2、3、4、5、6、7、8、9、10、11、12、13、14。
As an electrical stimulation formula here with a task, which is a counting task, induce speech arrest.
1、2、3、4、5、6、これくらいのスピード。はい。1、2、3。はい、ストップ。はい。
So stop. So these are severe on positive model area.
ベロまっすぐベース。まっすぐベース。はい。
So
そのままでいってください。はい。はい。
during
OK。ベ
stimulation.
ロ。はい。今、ベロ引っ張られましたね。はい。ね、
So she says that her tongue has not protruded. So this is the case at an electrical stimulation induced speech arrest.
はい。よいしょ。はい。せーの。はい。すいません。
So this slide shows the oral mass contraction on positive motor area. You see here again. Here. So another case, the case mapping during the more removal.
いきご。はい。いきます。せーの。はい。あ。出にくい。出ないね。
An electrical stimulation with ACNS picture naming, induced speech of words.
はい。あらら。
So we confirm the aphasia in bronchial area. So this case, the case of the speech arrest, but on frontal right field. So let's see. I must only nose without eye. So you can see that this is eye deviation. So electrical stimulation of frontal eye field induced right eye deviation. So false positive case, we show. So are they the case of speech arrest, but very several case. So speech, not here, but this is referring the comparison. So even minimal electrical stimulation with a task on motor area, so induced in this case interrupter generalizes conversion. So this patient could not continue removal under wake status. So there is the three important points of this of intracranial language examination under awake craniotomy. Firstly, adequate task selection, and secondly, minimal mapping technique and decision making for maximal extirpation, and finally, precise identification of functional area. So here is an important concept of EMS and contribution to safe examination, better patient outcome, and operators' skill. So here is a quantitative evaluation of efficacy of EMS. We create language examinations simulator to evaluate the usefulness of this EMS, comparing two quantitative outcomes between users versus non-users. So total test duration and the number of information exchange scores decrease, demonstrating the usefulness of EMS. So we share this real-time monitoring in OR. All the OR staff understand what is going on. So the last topics, the predicting surgery and telesurgical support. So in glioma surgery in SCOT at our university, we have developed SCOT in 3 stages from old to now. And now we experienced over 2,200 cases, MR guided navigations, and over 540 awake surgeries. Sorry, this. Okay, and this first stage is from 2000, and second stage at 2014, and third stage at 2019. So this is the brain mapping seen with EMS, our previously developed device in OR, we experienced over 540 cases since 2004, and now with an update version. So we called the advanced precision guided surgery system as a smart cyber operating theater we called SCOT. We can optimize the difference pre-operative and update present condition in OR this in like timeline. So we advanced the precision guided surgery system in SCOT. So we propose a future predicting glioma surgery in SCOT. So now the examination. So plan A, is the rejection range, can provide better survival rate with more risk of post-operative complication. This slide one. The rejection rate was 95, but the complication rate is higher. Complication than this B, plan B, this here, the very short, a smaller removal. So we manage the patient future perspective depending on tumor resection rate, as well as the post-operative complication rate. Now in our HyperScott cyber operating theater, we utilize surgical support using advanced medical device, which are open MRI to confirm brain shift and residual tumor. Surgical navigation system to visualize tumor and surgical instrument, 4D, 4K, and 3D video microscope and patient monitoring. At HyperScott, we promote the surgical decision support system called Strategy Desk. This system is successful for supporting real-time decision-making in Tokyo Women's Medical University. However, this is limited to local network. In another standard Scott at Shinshu University Hospital, we connected 17 medical devices between the Scott operation room and the strategy desk. We experience a real-time advice, that is telementoring, via strategy desk to operating surgeons. However, this is limited to local network. It shows that Professor Muragaki, Hongo, and Professor Goto. So this slide shows the schematic of 5G-based interoperative information sharing system between Tokyo and Hakodate. Our next stage of telesurgical support is to the world, if possible. Now, we have already evaluated our telementoring, that is doctor to doctor, by Scott locally. In the next stage, we promote telesurgical support. That means doctor to patient with local doctor present. So surgical data transmission using 5G network is evaluated. So testing between Tokyo and Hakodate, 682 kilometer distance, and sharing Scott big data, for example, 4K images on the cloud 5G network provided by Docomo. So I finalize my presentation. So thank you for your kind attention. I greatly appreciate all the audiences in this meeting. Thank you very much.
Thank you very much, Professor Tamura, for the interesting presentation. I would request Professor Sharon to say a few comments about Professor Tamura's presentation.
Okay. Thank you very much, Professor Tamura. I think all of us are very impressed with your presentation and also your center. I'm sure most of us would like one day to be one of those centers where we can connect with you, right? I just like to ask one question, because we do also awake surgery in my center. I'm not sure whether this is a common problem you have at your side, but because here in my country, some of our patients speak more than one language. They speak sometimes 2 languages, they speak sometimes 3 languages. So can you just, suggest, or do you have any suggestions how we can go about testing, this? Because we've come to realize, like, we have one main language, and what you're testing is basically the main language where we always sort of know where the area is. But then when it comes to the secondary languages, sometimes they are not actually at that appropriate area. They can be elsewhere. Okay, adjacent sulcus, adjacent gyrus. So how do you go about? I mean, have you come across any kind of cases like that?
Yes, it's a good question, because in your country is your
in
country.
Malaysia. I'm in Malaysia. So Malaysia,
Okay.
Malaysia, I mean, Southeast Asia countries, or Malaysia, Singapore, a lot of us, the patients speak English, maybe Chinese, Mandarin. Sometimes they speak even their other languages, Malay language, things like that. Yeah.
So we have some yes, about 10 patients who can speak the several languages, for example, Chinese and Korea and other countries, including US. And so we can manage the, firstly, the task is varied. So we can put and set the many kinds of several kinds of tasks. For example, the Korea, Japanese, English, and so on. And also the very poor thing is the translator. Translator is just beside in awake craniotomy. So to if the confirmation is very difficult, the translator can translate in the operating room. So we have 2 or 3 cases. The translator is just beside the patient in the operating room. It was very useful. And in EMS, we can set the any other languages task maximal 10 series. So we can set the many kinds of task languages. So it is it's an answer. Can I just answer? Okay.
I think Ben, you have a question. Is it Ben?
Yes. I want to echo with Sharon's questions. So because I'm going to have the Singapore patient who is a multi-language, so going to have a operation for Gauma. The tumor is at the right frontal region. So I wonder, in maybe Sharon or Dr. can share, like, in your country where the patients are multilingual. So how would you first of all, how would you can you do the functional MRI for a multilingual person, or how would you conduct it? And the second is, during the operation for awake surgery, how would you assess the multi language during your surgery? And my the third question is about the postoperative. So how would you assess the postoperative function of a multilingual person? I think these are not very common for us to handle.
This is a good question. So also, we have some. If we have much time, we can try to multilingual task in the operating room for functional MRI testing, but maximum 2 types. And also in operating room, we can assess the multilingual task in operating room, and we have confirmed the 2 different sites of language area was confirmed. So it is very important and it is very interesting things. The language, for example, kanji, you know that kanji, character lang, and
Yes.
hiragana and words were just beside or different area. So it is very good things and good question to confirm our language function. Yes.
Just another interesting question about the Japanese. So
Yes,
because in Japanese, they have kanji.
Yes,
They have a Chinese character. So have you tried to map those kanji? Is it separate from the major language center like the left side broker, or is it a bilateral phenomenon for this kanji? Because it's quite unique in Japanese, where you have a Chinese character.
It's a very interesting.
Just an interesting
Okay.
question.
The Chinese patient has come. I will try. Thank you. Okay. Thank you very much.
Thank you very much. Very excellent operative setting.
In this system, installed in Mumbai in Tata hospitals.
Oh, I see.
In 2019. So yes, Professor Ali has explained, has installed for the managing to install this system.
Does that mean that the whole operative theater need to be set up as a whole unit? So during the setup of the hospital, if we need to install your system, then we need to assign the whole operative theater for the system to be installed. Is it? Yeah, Scott.
Oh, yes. It is also the medical device. We want to sell as a medical device in all the operating systems, including the intraoperative MRI. Yes, it's a mainstream, and this system gathering all the information in operating room. So it's a very interesting story.
Yeah, thank you so much. Sajin, you have something to say?
I think maybe the bit shy. You have lots of questions to him, I think.
Yeah.
Thank you, Dr. Professor Tamura. That was a very futuristic and fantastic presentation. I would like to ask you about your MRI.
Yes.
When you do intraoperative MRI, do you repeat a DTI in the MRI, or you use the preoperative DTI?
It's a good question. So as to the intraoperative MRI, in Japan, we have 2 types intraoperative MRI. So we have our MRI is a middle tense, so 0.4 Tesla. So now you or some sites using 1.5 or 3 Tesla MRI in the operating room. So if you use 1.5 or 3 Tesla MRI in the operating room, you can manage the fractography in the MRI room. But in our low 0.54 Tesla MRI, we cannot use the tractography, but we can use a DWI, which shows the lower limb. So lower limb fiber tract in the operation room. So that is a limit of the other examination using intraoperative MRI scan. But our MRI scan 0.4 Tesla is just good image quality without some artifact of the high Tesla MRI scan. So you can choose of the two.
So it is reliable for lower level. So DTI for
yes, we use DTI, yes, tractography for high Tesla MRI. So we only use the preoperative DTI, so fusion in the operating room.
Okay, my next question is in which tumors do you perform awake? Generally, just left side or right side or both sides, or how do you plan?
Sorry, right child, you say the.
Do you do only left side awake or even on the right?
Okay. Generally, awake craniotomy is a 1/4 of all the surgery. So in 2,200 patients, we provide the awake surgery 540 patients. So 1/4, about 1/4, and in left side is 3/4 is the left side, and in our institute, even if the right side in tumor, we want to detect the motor function in right side, even if the right side tumor. So in awake craniotomy, we have confirmed the left hand or legs motor function directly in awake craniotomy. It is very useful, I think.
Okay. And do you use both cortical and subcortical monitoring? So how do you stimulate the white fibers after you have removed the bulk of the tumor?
Yes. Cortical mapping is just the first beginning stage of the tumor removal, and of course during tumor removal, we use the mapping with the white matter mapping during tumor removal. It's a routine work during tumor removal. Yes, of course, it's a good. Thank you.
And my last question is, what is your belief about supramaximal resection of glioma? Do you practice that, or you do a gross total resection? What do you think?
Gross total resection is very good things, and it depends on the tumor pathology. I think if the grade 4 tumor, we use the gross total resection using the gadolinium enhancement. And apparatus. And if the 2 or 3 grades in gliomas in the pathology, we intraoperative our examination, we can use the DNA aneuploidy in our room during the operation, in our room. So we use this system, and if the tumor was grade 2 or 3 and not 4, we try to the maximum, not supratotal resection, because after the we can use the second step surgery using the MRI, intraoperative MRI scan. So this is my opinion, but supratotal resection is also the controversial and good things, so we can discuss. Okay.
Yes, I agree. Even we do mainly a gross total or radical resection. Basically, our concept is to do an en masse surgical resection for localized gliomas, basically. and that is a good resection with that.
And
Thank you very much, and congratulations for your great work.
a good resection is good. Yes, thank you.
So, thank you very much, Professor Tamura, for great interaction. May I request our second discussant, Professor Alexander Wozniak, to say a few comments about Professor Tamura's presentation and few points about. You always give a lot of tips for the young neurosurgeons. So, few tips about awake craniotomy and monitoring for young neurosurgeons.
Thank you, Sachin. I'm sorry I was late. I had some problems with internet. I'm not at home now, but it took time. So I'm sorry I missed a big part of your lecture, Professor Tamura. So I'm sorry, but I have some remarks about our experience of surgery of glioma with the eloquent areas. So in my department, we do not have intraoperative MRI. So we use some tricks. So we have intraoperative neuro monitoring. We perform awakened surgery, but we have not MRI. Instead, we have ultrasound, intraoperative ultrasound. We use it routinely. And sometimes we use our diagnostic MRI. So sometimes we transport the patient to the MRI if we need it. We'll switch him to the ventilator in the MRI, perform MRI, then re-register at the navigation and go on the surgery. We do it very rare, but we have this trick is possible in some circumstances. This is the first, and the other things what I wanted to say that we have neurosurgeon has more and more tools and gears in his OR, but our mind is not the artificial intellect. We cannot analyze all this information from all our machines, all our gears. So what I prefer to do, I prefer to use such a rule of preference to rely on the most informative gear at the situation. For example, when we operate the eloquent area, of course, the awakened patient with the neuro monitoring is the most informative tool. So I wouldn't rely on ultrasound. I wouldn't rely on photofluorescence. I will rely only on the function, on this function. When we are free, when we operate in not eloquent area, of course, the ultrasound is very good because I can see the border of the tumors, and so I can extend my resection very safely for the patient. So this is the rule I do it, and what I'd like to share with my colleagues. So, but unfortunately, intraoperative MRI, it's a very expensive gear. It's expensive to buy, it's expensive to maintain. Not all hospitals, especially in low income and middle income country, can let themselves. So we must be flexible in our practice and to do the best for our patients. And first of all, the functional result is always more above than beautiful post-op MRI or CT for the patient. So this is my message. And Professor Tamura, thank you very much. Thank you.
Thank you. Nice comments. And MRI is very, very expensive. You see that, but MRI, low Tesla MRI is not so expensive than the high Tesla MRI. But
I agree.
Even if the low Tesla MRI is also high.
I think, Alexander, maybe you can send your colleagues to his place as a fellow in the near future.
Yeah, of course. Let us be in contact. Thank you very much. Thank you.
His institute is I think top runner. I think such kind of full examination for glioma surgery.
Yes, very big experience.
Yes,
So many
it's
surgeries.
definitely. Thank you very much.
It's impressive. Thank you.
Thank you.
Thank you.
Sachin?
Are there any other questions from anybody, any delegates or participants?
Pirzad, you want to say
If
something?
not, Professor Pirzad, you are unmuted.
Yes, thank you. Konnichiwa. Salam and thanks.
Thank
Thank you, Professor Tamura. Very nice and advanced presentation and advanced use of technology in neurosurgery. But we also use intraoperative ultrasound and awake surgery in Afghanistan. And I like to know that the possibility you proposed before about telementor by Scott, and if it's possible for Afghanistan neurosurgeons as well, is it possible? And the other things, what about the frozen section? Do you do biopsy frozen section during the operation and advise this or not? Yeah. Thank you.
Thank you. We have in our operation, we have the not only frozen section but also the just DNA aneuploidy test machine in the operating room. So we have also get the information in 10 minutes just before the information of frozen section examination. So it is very informative. Thank you very much.
And what about telementoring?
Sorry, what about
you proposed
yeah.
telementoring by
Yes,
Scott
many things to solve them. One thing is images, operative images for the video image and so on is very very high level, very amount of size is very big, so it is difficult to transfer from Japan, for example, Japan to other countries, and so it is very and the security problem and so on. It's many things to solve, and also the technique to transfer. In Japan, many countries try to do, but it is now many things to solve it. Thank you.
Thank you. Arigato. Arigato gozaimasu.
Thank you. Are there any other questions?
Salam, Dr. Burhani.
Salam. Thank you very much. I apologize because I'm driving, but I'm enjoying your conversation and also a good lecture. Thank you very much. I think functional neurosurgery is a big issue, and there's more and more progresses. Just already this morning we had our own webinar with Afghanistan and other countries in the world, also about using good tools during the operation, and as we see in the opportunities in Afghanistan is for now is ultrasound is the best one next to the awake craniotomy, of course. So very important is to monitor the patient, the vital function. So I'm enjoying your conversation. Thank you very much.
Thank you. Thank you also very much.
Thank you. Thank you, Professor Burhani.
Thank you, Professor Burhani. So we'll go ahead with our next speaker. My pleasure to invite Dr. Dragan Jankovic, MD, PhD, who is neurosurgeon at the Department of Neurosurgery at the University Medical Center of Mainz in Germany. PhD student of neuroscience, and he's going to talk about CNS YNS Webinar. Over to you, Dr. Dragan. can't hear you. You have to unmute yourself.
Do you see my presentation?
Yes, we can see and we can hear you clearly.
Just a second, please, because I don't see. Yes. Dear colleagues, dear professors, dear colleagues, thank you very much for the invitation. For the first time, GNS speaker, that's honor for me. And today I will talk about CNS hemangioblastoma in adults. I am a neurosurgeon resident here in Germany, in Mainz, and today I will talk. My lecture are based on results on our 3 papers in the last 3 years with Professor Kenan Arnautovic aus USA. I will try to be not too long, but about this topic can we talk about hours. So that's just a part of our PubMed about PRISMA guidelines for our patients, and we identified through PubMed database about 1,500 papers about hemangioblastoma pediatric in adults. And after our exclusion criteria, we included in our articles in total 539 articles with total of 3,180 patients. So the increased frequency of papers published in this century at the end coincidence with the advancement of novel neuroradiological techniques, and also about and also as well as the development of new surgical techniques. What we know about from literature that hemangioblastoma are relatively rare tumors, well-vascularized benign tumor of CNS. Within the CNS, hemangioblastoma most often appear in the posterior fossa, and although they are histological benign with low oncological morbidity, due their location and growth trends, they can cause a significant neurological deficit that can impair patients' quality of life. When we talk about spinal hemangioblastoma, they are the third most common primary spine cord tumor, following astrocytoma and ependymoma. About content of the distribution. So on these pie charts, we can see that the continental distribution of patients was most common in Asia, in all 3 groups, and followed by Europe and North America. It would be highly speculative to hypothesize that the rate of hemangioblastoma in highest in Asia, but this finding clearly needs further investigation by adequate demographic research. When we talk about location, the most tumors were located in posterior groupa, in cerebral location, was slightly more frequent in patients with von Hippel-Lindau disease in the sporadic than in the sporadic group. And what's important to say that almost 1/3 of posterior fossa hemangioblastoma were extracerebral. Here I mean about on brainstem, CPA, and foreventricle. On the right side, we can see our supratentorial group, and the most common location was cellar or paracellar location, followed by frontal, temporal, and parietal location. When we talk about spinal group, then our study confirmed that the most common hemangioblastoma location in the spine is in dorsal cervical region, followed by thoracic and lumbar region, and more than 55% of spinal hemangioblastoma are located in posterior root entry zone. And we think that this pattern is due to the distribution and quantified of embryonic precursor cells. Adult hemangioblastoma, on the right side, so we can see this most commonly occur intramedullary in 37% of case of sporadic, and in 31% of hemangioblastoma with fall hippolympal disease, followed by the extramedullary location in the both groups. As a standard for diagnosing and preoperative planning, monitoring, we use, and the gold standard is magenta MRI scan. The appearance of a syrinx or a cyst was reported in 43.9% of cases, and it is most often appeared in the thoracic and in the cervical level. Important to say is that our study, we found no association also between syringomyelia levels and the symptom severity. When we talk about symptoms, here we can see on the left side posterior fossa group, on the right side subtentorial groups, and two pie charts. So presenting symptoms and clinical signs were mainly related to the tumor size or a cyst associated mass effect, and if a cystic component was present, most commonly symptoms were increased ICP about 50%, and increased ICP was more common in the patient with von Hippel-Lindau disease that we can see here. Then in sporadic group, where was ICP the most common in 42% of patients. Our study showed also the cystic tumor having a larger volume and producing a greater mass effect together with the multiple tumor effects are probably responsible for the increased ICP, which occur more frequently, as I said, in patients with fall Hippel-Lindau. When we talk about spinal group, in the spinal group, symptoms and clinical signs also depend on the tumor site, on the location, and as well on their compressive effect of the spinal cord, and clinical signs are also related to syrinx associated mass effect, and patients with fall Hippel-Lindau disease. In the patient with fall Hippel-Lindau disease, the most common symptom was sensory deficit, while the pain was the most common symptom in patients with sporadic hemangioblastoma that we can see here and here von Hippel-Lindau. In our study design, we made morphologic types according to the histopathological findings in literature. We have solid cystic with mural nodule, and both solid and cystic type. Solid hemangioblastoma in our 3 papers were the most common, followed by cystic type. Some investigators, authors, advocate a typical morphological spectrum of 60% mostly cystic and 40% mostly solid tumor, but our 3 reviews in 3,000 patients showed an opposite ratio between solid and cystic with solid predominance, and the solid tumor was mostly frequently presented in both sporadic and von Hippel-Lindau groups. Regarding to the treatment, surgery is the first choice. The complete tumor resection remains the most effective treatment for hemangioblastoma with minimal morbidity. And we can see that in posterior fossa group, it's about 88%, followed to by partial resection with 4%, and subtotal resection in 2%, and in supratentorial groups, it's about, also total resection is about 80%. We did not record any major difference in the surgical trajectory over the years, but it is really important to say that in our studies design, we reviewed all papers that published on the PubMed in the literature between 1885 till 2020. So that is a 45 years period, and we did not record any major difference in surgical strategy over the years. And although is the well known that hemangioblastoma is highly vascularized tumors, the blood loss intraoperative were too restrictive to be analyzed, but in the paper that reported, it's about 30 to 40, 300 to 400 milliliter. Regarding to the treatment in the spinal group, the guidelines, the American guidelines of National Comprehensive Cancer Network suggest tumor observation if the tumor is asymptomatic, microsurgical resection recommended in symptomatic patients. In spinal group, in our results show that total resection was performed in 84% of patients, followed by subtotal resection, radiosurgery, and partial resection. And when we talk about postoperative complication, the most common complications were intracranial in 31 point of patients, consisting of postoperative hemorrhage, hydrocephalus, or pneumogameningocele formation. Important to say that we did not record major change in type, rates, and trends of complication over the years, and rate of complication were similar in the first and the third decade and the fourth decade of our review. So in the 2019 and 2020. We can see that also the after in posterior group is some often infections of the second place, and in the supratentorial group infection was reported in just 1% of patients. In spinal group, postoperative complications were reported in 3% of patients. The most common complication in the published paper was cerebrospinal leakage, followed by postoperative bleeding. And when we talk about mortality, overall postoperative mortality was 5.1%, which at the end is in the line with previously published studies. Outcome after complete tumor removal, the prognosis and the surgical outcome are generally good. For variable, we have four groups: favorable, fair, poor, and dead. Favorable outcome was the most common recorded, and there were no major difference in outcome between patients with von Hippel-Lindau disease and those who's having a sporadic tumor. When we talk about postoperative mortality, overall mortality in patient in posterior group, it was higher, 10.3%, and in supratentorial group, the mortality was 4.1%. In the spinal group, when we talk about outcome, although hemangioblastoma are very well vascular tumor that require detailed planning, the diagnostic, the outcome of treatment in spine is also favorable with minimal postoperative morbidities. And our systematic review showed that sensory symptoms improved in 72% of patients, and pain improved in 90% of patients. There was no difference between the treatment outcome of sporadic cases and the von Hippel-Lindau cases, and also no statistical significance was found between intraoperative blood loss and the treatment outcomes, and also outcomes vary depending on tumor location, about vascularity, morphology, which can make resection extremely challenging in some cases. So therefore, preoperative neurological status was also important predictor of the long-term outcome. At the end, we can conclude that the tumor occurred most frequently in the 4 decades of life. Here we can say that a group of patients with von Hippel-Lindau were younger than a patient in sporadic group. There is a male predominance in the sporadic group of the CNS hemangioblastoma. The solid type was the most commonly typed generally, and although symptoms of different locations are completely different. Symptoms depend on tumor size and the location, and the management of the both tumors is based off neurological symptoms, tumor size, morphological aspects. We can say that total tumor resection remains the treatment of choice, the gold standard in all 3 groups, and in all 3 groups have a favorable prognosis. The reported recurrence, very important, was 7.9% for sporadic group, and in patients with von Hippel-Lindau disease, the reported recurrence rate was 22%. So we can say then that is related. So recurrence is related with subtotal and or partial tumor resection, the presence of multiple hemangioblastoma, and also present in patient with von Hippel-Lindau disease. At the end, we can say that surgery of adult hemangioblastoma is demanding and challenging risk and challenging task for neurosurgeons. And at the end, thank you very much, and greetings from Mainz, Germany.
Thank you very much, Dragan, for excellent review presentation about CNS hemangioblastoma. I request Dr. Shah to please kindly say a few comments about Dr. Dragan's presentation.
We can hear you.
Sharon, you are muted.
Sorry, okay. Thank you very much, Jakovic. I think your presentation was very good. You made a good conclusion. This is just you did a analysis of the studies that you could get up from PubMed, is it? Or is it an analytical study, or is there anything based from your center?
So that is a systematic review over 3 systematic review in adults patients over 40 years. So that was all published. So series and case reports in the last 40 years that colleagues are published and it is in the PubMed database.
So how many of these cases did you realize that it correlate with von Hippel-Lindau? Did you see that there were how many of them? How many percentage of them actually had von Hippel-Lindau? Did you find out that numbers? Did you get those numbers?
Multiple tumors, or
yeah,
the multiple tumors was mostly just in few cases. As case reported in sporadic. I think that was 1 or 2 patients. The other was reported always in for Hippel-Lindau disease, and it is about 22 to 25% of patients with for Hippel-Lindau disease.
And did you find the recurrence rate? Recurrence rate said not in the same site, but maybe different sites. Was there anything about that?
About recurrency in multiple.
Recurrence, yeah. In different, yeah.
All multiple tumors has the recurrence. All multiply have recurrence. Yeah.
Because you mentioned something about some of the tumors just being observed. So these tumors were tumors without any neurological symptoms, patient being well, so just followed up with imaging, right? Yeah.
Yes, I said that the in Germany and also in the USA, the cancer network suggests that if the patient has no symptoms, we can go to Rachel rating, or if the patient is symptomatic, then we should suggest a surgery or radiosurgery, but surgery as the first choice.
And radiosurgery, did you actually have any papers mentioning the outcome?
In the which surgery?
Radiosurgery, not for surgery. Surgery, yeah, we know, but for radiosurgery, did you?
The radiosurgery was reported always after first surgical resection. So if the patient is resected, and if the patient has after then recurrence, then we performed a radiosurgery.
All right, thank you.
Thank you very much, Sharon. May I request Dr. Abida Shah to please make a few comments about Dr. Dragon's presentation.
Dr. Dragon, there was quite a comprehensive review of hemangioblastomas over the last so many years, and congratulations for your effort. I would like to know, have you separately analyzed brainstem hemangioblastomas, brainstem solid hemangioblastomas in your series?
We do not analyze. We analyze more just according to a location, because that was a study design in such a big systematic review. We analyze according to the brainstem just as a location, but some tumors was located from the brainstem to the pons, from the brainstem to the cerebral hemisphere. So if the patient has more of 50% of if a tumor is located more than 50% of part of tumor, then we located just that's the brainstem. But we did not brainstem locations, just a brainstem. We just locate in brainstem if the tumor was reported as a brainstem tumor.
Because brainstem solid hemangioblastomas are one of the most difficult neurosurgical problems to treat. Because post-operative, there is a lot of neurological morbidity. So in our experience, that is the worst hemangioblastoma location that you can have. Especially if it is a still big solid hemangioblastoma. So, anyways, thank you for your presentation, Dr. Dragon.
Thank you very much.
Dr. Alexander Wojciak, could you please make some comments about Dragon's presentation and some your expertise about excision of hemangioblastoma?
Okay, thank you, Dr. Yankovic. My congratulations.
Thank you.
Very good analysis. Thank you very much. Thank you very much. I was even surprised that there are so many unfavorable results, especially in posterior fossa hemangioblastoma. But I'd advise you to try to separate. Just I absolutely agree with Dr. Shah, because cerebellar hemispheric hemangioblastoma and intra and brainstem hemangioblastoma are absolutely different. So there is a sense to separate them, because the outcomes of cerebellar is much better. There were almost no problems with this, but the brainstem it's a real problem. So I'd separate this to improve the outcomes from cerebellar hemangioblastomas. I have some comment. Maybe let me express some comment from my experience about hemangioblastomas. So first of all, the hemangioblastoma, it's a very heterogeneous group of vascular tumors. It could be like a low flow AVM, and it could be like a high flow AVM, and even more than AVM. And when you start to operate, you do not know how would it be. You just try this tumor. The technique of surgery is very similar to technique of AVM surgery, with one exception. You can gently coagulate and shrink the hemangioblastoma. Sometimes it's more difficult to do with the AVM. Of course, it's possible, but not so much like with the hemangioblastoma. The technique of smooth coagulation and shrinking is very helpful. Another important thing is that it's very difficult to stop. Once you started to operate it, it's much better to be radical, to try to remove all the tumor, because if you leave a piece of tumor, you cannot predict the consequences. So it may be venous infarction, it may be very fast growing of the tumor, and so in my practice, I always try to be radical in surgery of hemangioblastomas. Concerning intramedullary hemangioblastomas, you remember that the spinal cord gets the blood supply from anterior spinal artery and to posterior. That is why if the hemangioblastoma is located posteriorly and abuts to the surface of the posterior part, it's very often it's wise to use the posterior lateral fissure to approach this tumor, not use the midline, but use the posterior, the dress zone to remove this tumor. It's my remark. And concerning the von Hippel-Lindau, it's multiple tumors. They can recur again and again. So in my practice, I operate only symptomatic tumor. I observe the patient. Once one of them start to be the symptomatic, I operate the symptomatic. And if it's possible, I remove the neighboring tumors if it's possible and if it's safe at the same procedure. I have an experience when I removed six hemangioblastomas from the posterior fossa at once, but only one was symptomatic. But I removed all the six with good result. And so, thank you very much. And once more, congratulations. It's a really big job, and it's really interesting. It's very good analysis. So, thank you very much. Thank you.
Thank you for your comment.
Tamura Sensei, do you have any comment?
Thank you. Thank you very much. Sehr gut, Dr. Janovic. Dankeschön. Teşekkür.
Thank you very much. Statue, we don't hear you.
You need to unmute yourself.
Tamura Sensei, you are muted. Can you unmute yourself?
Very sorry.
Yes.
Yes. Before I worked in the TWMU. I have just studied in radio surgery in Marseille. So we have some cases for the hemangioblastoma. The other doctor said the hemangioblastoma can be treated as with radiosurgery just after the confirmation of the pathology. So your study and your perspective of this study is very useful, and hemangioblastoma is just very important to confirm the histopathology, and this is not tumor, but not the simple vascular diseases. So very interesting story, and that is a good job from my comments. Thank you very much.
Thank you for your comments.
Richard, thank you very much for excellent lecture. Just I'm asked the same question to you of the Tamura Sensei, because the pathology is totally different from ABM, the blastoma. So I think why the radiosurgery is effective to the hemangioblastoma, and also where is the targeting point of the pathology of the hemangioblastoma?
Pathology.
Can you hear me?
Yes.
Yes, I'm question. Yes, I ask you. The pathology is totally different from ABM, the hemangioblastoma. So they don't have such a targeting the histopathological point. So if you learn something about the histopathological things of the hemangioblastoma, why the radiosurgery can affect to treat?
Yes, it's very important question, and this is difficult to say the why the radiosurgery plan. Just radio just is the power of the radiosurgical effect. Not only the just stop the surrounding vessels, and this is a concept, I think. So this is just different from other AVM concept to treated by radiosurgery. So it is very difficult to say, but it is, I think, some theory or the mechanism to do the efficiency from. So, but I don't know why or I can answer your questions completely. Sorry.
山田先生、ありがとうございました。Thank you very much. So, Sachin, thank you so much.
Okay, thank you all the discussants and participants for an interactive discussion, and Dr. Jagan, fantastic review presentation of about CNS hemangioblastoma. I think for younger surgeons, it's very important to review such kind of articles to understand the pathology in more detail, so that we can develop some more strategic approaches to tackle this kind of problems. So I think it was a fantastic webinar today, and both the lectures were excellent and very interactive discussion. I'd request Professor Sharon to say some final remarks, and then Professor Yoko Kato for the concluding remarks. Dr. Sharon?
All right. I'd like to thank, first of all, Professor Tamura for a very modern and enlightening talk, and also to Jakovic. I think doing an analysis is very important. It helps us to get a grasp of what's happening and how to go forward from where we are. So it's great to have everyone here again on a Sunday and having an interactive debate and exchange of knowledge. So thank you again for joining us, and hope to see you all again in the next upcoming YNS webinar.
Thank you very much.
Okay, thank you very much. So Tamara Sensei, thank you very much. I think you should continue the very tough work. I think maybe it will take I think 5, 6, 7 hours for remove of the total the glioma on your schedule, I think. And also the Jankovic is okay?
Yeah.
Pronunciation is okay? So you're from originally from Bosnia. Yes.
Germany.
I'm from Croatia. Origin from Croatia.
Croatia.